Hi everyone, my name is Sean Wasserman from the Division of Infectious Diseases and HIV Medicine in the Department of Medicine at UCT and Critical Care Hospital. Today we are going to discuss fever in hospitalized patients, and this is a MBCHB Year 4 seminar. Just to say that the focus is going to be on a clinical approach to assessing patients with fever in hospital and not on management. So, let's start with a case. Imagine that you are a first year intern and you are on the wards on call, and you get a call from the nurse in the medical wards to say that a 69-year-old woman who was admitted 4 days ago because of a stroke, resulting in a dense right hemiparesis and aphasia, has now developed a fever. So you run up to her bed in the ward and you open up her chart, and this is the first thing that you see. You see her temperature chart. And let's just go through this for a second. So on the y-axis, I'm sure you're all familiar, but just to refresh your memories, on the y-axis is temperature in degrees Celsius. Each big block is 1 degree and each small block is 0.1 degrees, so there's 10 small blocks for each big block. And on the x-axis is time, and the nurses usually write in the date over each block, and each block represents a day. And you can clearly see here that there's variation along the baseline, but an increase over the last 2 or 3 days, definitely above that solid black line of 37 degrees, and reaching a peak of 39.8 degrees Celsius. So these are the main questions that you are going to have to address as a doctor, and the main things that we are going to cover in this lecture. Firstly, does what you see actually represent a fever? And we're going to talk about what the definition of a fever is and temperature variation in people. Secondly, once you've decided that she's got a fever, and once you've decided in general that your patient has a fever, how do you actually deal with this? What is your clinical approach to someone in hospital who develops a new fever? And if you take a step back and think about it, there's a lot of potential causes, and so it's very important to develop a systematic approach to dealing with this very common problem. And then finally, at the end, we're going to discuss 2 very important ways to prevent hospital-acquired infection, which is the most common cause of fever in hospitalized patients, and that is management of peripheral venous catheters and urethral catheters. So in order to define what a fever is, we first need to understand what a normal body temperature is. And just like any biological measure, there's a lot of variation between people and between occasions. So when this is measured in whole groups of healthy people, there's quite a wide range, and the range is between about 35.6 degrees to 38.2, and this is in healthy people, so healthy people can have temperatures above 38. The mean in large population samples of healthy people is 36.8, with the standard deviation on each side of 0.4. But the so-called normal body temperature of 37 degrees Celsius only occurs in about 8% of people. So you can imagine there isn't such a thing as normal, and there's a lot of variation, and we have to take into account, as always, the clinical context. So if someone has an elevated fever, are they sick? Are there associated symptoms and signs that go with it in order to call it a fever? The other thing about normal body temperature, about body temperature regulation, is that it follows a clear circadian rhythm. As you can see on normal temperature charts, there's no flat line. The temperature varies between morning and afternoon in these up and down spikes. It's highest in the afternoon, but not usually higher than 37.8. And it's lowest early in the morning, not usually higher than 37.2. The other important consideration is the site and the method that's used to measure body temperature. So when it's measured centrally, say in the right atrium, which is the ultimate source of measuring body temperature, it will be higher than, say, if you measure it on someone's forehead using one of these commercial pads, which are unreliable. So taking into account all of this variation, how do we define a fever? Well, it's actually completely arbitrary. Well, not completely arbitrary, it's quite arbitrary based on the distribution of temperatures in normal people. And so taking the outside end of that distribution and just putting a cutoff above which we consider a fever, the convention and consensus is that a fever is defined as a body temperature of more than 38 degrees Celsius, and it's usually measured in the oral cavity or in the axilla. In our hospital, we measure it in the axilla. So now that we've decided that our patient has a fever, and she clearly does because her temperature is way above that cutoff of 38 degrees Celsius, we need to figure out how we're going to help her. And we need to develop some sort of clinical approach to patients in hospital who develop a fever. And I think it's very important to remember what the cause of a fever is in general, including people in hospital. So any trigger of a systemic inflammatory response can cause a fever. And this is quite a complex process driven by various cytokines and their interactions with the temperature regulation center. But understanding that an inflammatory response can lead to a fever, you can imagine that there's lots of causes, both non-infectious and infectious. So in our approach, I'm going to start with just listing the important non-infectious causes, which are just things that you're going to have to remember. And these are very common and need to be looked for in almost all patients. So what are the causes of inflammation in a hospitalized patient? Well, the first most important cause is venous thromboembolic disease, so deep vein thrombosis or pulmonary embolus. And clearly you can understand that patients in hospital are at higher risk of thromboembolic disease because they're immobile, they have chronic medical conditions, they're on medications that could cause increased risk of thrombosis, etc. So this is a very important consideration. And every patient in hospital with a fever that you go and assess, you should examine their calves, even though the sensitivity isn't that good for swelling, and just bear this possibility in mind. The other important non-infectious cause of fever in people in hospital is the presence of bed sores, so even non-infected bed sores, because remember, bed sores are tissue necrosis, and tissue necrosis causes inflammation. And so patients that are immobile in hospital with a fever, it's very important to examine them thoroughly and look specifically for the presence of bed sores. Another important cause, and I think is often overlooked, is infarction. Infarction causes tissue death, inflammation, and can of course lead to fever. And someone who develops a new infarction, so in their brain, which we call a stroke, or a myocardial infarction or heart attack, or even infarction of their peripheral tissues if they've got peripheral vascular disease, can get a fever. And you can imagine that these things can occur in people who've been hospitalized for another cause, or in fact, even if the original reason for hospitalization was infarction, they can have a subsequent one, and that can cause fever on its own. Of course, these are diagnoses of exclusion, and you have to think of other things as well. In our setting, an important cause of fever in people in hospital potentially is immune reconstitution inflammatory syndrome, or IRIS, where HIV-infected patients start antiretroviral therapy and then manifest an inflammatory presentation of an opportunistic infection. And so it's important to take a history and consider whether your patient has recently started antiretrovirals. And then finally, another important cause, but at the bottom of the list, is drug fever, which can occur in response to almost any drug, including antibiotics, but is a diagnosis of exclusion. The way that you prove it is to look for other causes first, which are potentially treatable and reversible and serious. And if your initial search doesn't yield anything, then consider stopping drugs, and the diagnosis is made if the fever goes away after stopping the drug. Then we're going to move on to infectious causes. So your broad approach is considering causes of a systemic inflammatory response, dividing into non-infectious, and here's the list, and infectious. And infectious is a broader list, and I'm going to spend a bit more time on it. And it's very important to take a systems-based approach and combining that with an etiological approach. And I'm going to show you that in a second. So, taking a systems-based approach to infectious causes of fever in hospitalized patients, these are the systems that you should always consider. Number one, skin and soft tissue. And that includes drip sites, bed sores, surgical sites. Respiratory system. And we'll see now the most important cause is pneumonia. The gastrointestinal system, and that's heralded by the presence of diarrhea. Intra-abdominal, which is separate to the gastrointestinal in the way that I think about this, where we think about collections. A very important system is the urinary tract, and clearly having a urinary catheter is an important risk. Central nervous system and vascular, so endocarditis, are much less important and are affected in very specific situations. So in the next few slides, I'm going to consider each of these systems in a kind of systematic approach and think about the potential etiological causes from an infection point of view that can lead to fever in each of these systems, and try and understand how we can apply history examination and, less importantly, diagnostic testing to try and find a cause for fever in a hospitalized patient using this systems-based approach. The first system to consider is skin and soft tissue. The main causes under here are by far the most common: drip site infection, followed by surgical site infection, and then infected bed sores. If we think about what questions on history we can ask, either to the patient, or if they can't talk, as in this case, the patient with a stroke, their caregivers or nurses, things that are important indicators of a potential infection in this system is presence or recent history of a peripheral intravenous catheter or a central intravenous catheter for that matter, patients that have got surgical wounds after an operation, and in terms of bed sore, immobility, and I spoke about this earlier. So you can immediately see that just asking these three questions can lead you to a potential explanation for someone with a fever quite quickly. On examination, the most important sign to look for would be signs of local inflammation, so cellulitis that either surrounds the entry point of a drip or a surgical wound or surrounding a bed sore. And then in terms of diagnostic tests, which doesn't actually initially influence your empiric treatments, but I'm not going to speak about treatment now, is important to do a blood culture and potentially a skin swab under certain conditions. We don't often do skin swabs. So before I move on to the next system, which you can see here, I just want to add, because I don't actually know how to modify my previous recording of the other slide, that the most important bacterial causes of skin and soft tissue infection are the bacteria that live on skin. So gram-positive cocci, like Staphylococci. Staph aureus is very important and the most virulent, but other kinds of staphylococci as well, which we call the coagulase negative staphs, and streptococci, so group A strep pyogenes, and other streptococci. And then in patients with bed sores and potentially surgical site infections, depending on where they're located, gram-negative bacilli like E. coli, Klebsiella pneumoniae, and even Pseudomonas can also be causes. So moving on to the next system, which is the respiratory system, really the number one dominant cause of an infection in this system is pneumonia, so inflammation of the lung bacteria, of the lung parenchyma, caused by a pathogen, either bacterial or viral, and in hospital most commonly bacterial, and the bacterial causes are the same ones that we find in the community, like pneumococcus, Staph aureus. In hospital we see more gram-negative, so Klebsiella pneumonia is an important one, and this has implications for empiric therapy, which I'm not going to talk about. Occasionally, viral infections can cause pneumonia in hospitalized people if there's an outbreak of influenza, and these days, COVID-19. On history, really fairly obvious if you ask about it in most patients, and that is there's a complaint by the patient or their caregiver of shortness of breath, dyspnea. Also, you might see cough and have a high index of suspicion in patients who are at risk of aspiration, just like the patient that we've presented in the case now, who's had a stroke and is aphasic and is probably having difficulty swallowing. On examination, also fairly straightforward, patients have an increased respiratory rate, so they're tachypneic, and on auscultation often have crepitations. And by far the most important investigation to perform in this setting is chest x-ray. which will reveal the presence of lung infiltration consolidation and will confirm the diagnosis of pneumonia in a compatible clinical setting. So a really important cause of fever in someone in hospital. As soon as a patient is breathing fast, consider pneumonia as a possibility. So considering infections that can lead to fever in hospitalized patients originating from the gastrointestinal tract, by far the most important cause is Clostridioides difficile diarrhea, which obviously manifests as diarrhea. Now, C. diff diarrhea is caused when patients are colonized with the causative organism, C. difficile, which is a gram-positive bacillus, an anaerobe, and up to 30% of people are colonized if they've been in hospital for more than 10 days. But colonization isn't enough to cause diarrhea, which is the clinical manifestation of C. diff infection. A second hit is required for the organism to become dominant in the gastrointestinal tract, produce toxin which causes cellular injury. And by far the most important second hit is antibiotic exposure, which many of our patients have had. So on history, the most important things to ask is, does a patient who has fever have diarrhea? And putting them into a high risk categories if they've had any antibiotic exposure, but this really should be considered in any hospitalized patients with fever and diarrhea. The clinical manifestations besides the presence of diarrhea include abdominal tenderness, and abdominal tenderness is a very important warning sign because it may suggest underlying severe C. diff disease with complications and may require early surgical intervention. The diagnostic test of choice are specific C. diff diagnostics. In our hospital, we do a combination of an antigen and toxin test, and if that's inconclusive, we do confirmatory PCR. If that's negative, there are other causes of febrile diarrhea in hospitalized patients. So conventional causes like bacillary dysentery caused by Salmonella or Shigella or Campylobacter, which occasionally we see, or viral causes as well, which can cause outbreaks in hospital like noroviruses. And it would be important to send a stool for microscopy and culture if in any patient without C. diff with fever and diarrhea in hospital. I've separated intra-abdominal causes from GIT causes because it's clearly a different clinical syndrome. And when I talk about intra-abdominal causes, infectious causes of fever in hospitalized patients, I'm really referring to patients who've had a laparotomy and have got collections in their abdomen. On history, the number one most important question to ask is, has the patient had a recent laparotomy? And on examination, do they have abdominal tenderness? Those two things together should really cause you to consider that there's an intra-abdominal collection or some other post-surgical complication that's causing intra-abdominal inflammation. That is the explanation for the patient's fever. And that usually requires quite urgent abdominal imaging with either ultrasound or CT scan. Perhaps the most important, but actually one of the most difficult to diagnose causes of fever in hospitalized patients comes from infection of the urinary tract, and that is catheter-associated UTI, which is the most important risk factor for a urinary tract infection in a hospitalized patient. The reason why it's so difficult is because patients who are hospitalized with urinary catheters often can't give a history, because the reason why they've got a urinary catheter is because of some problem that affects the level of consciousness, or that there's underlying confusion because of severe underlying disease. And so it's very difficult to get a history. And the manifestations of catheter-associated urinary tract infection are very non-specific. Often we just see patients have a general deterioration, so become more confused, become tachycardic, have a systemic inflammatory response syndrome with the fever. There might be renal angle tenderness, but in my experience this is quite uncommon. There might be suprapubic tenderness, again much less common. And this is a very important diagnosis to consider high on the list after an initial screen on history and examination for skin and soft tissue infection, tachypnea, so pneumonia, and abdominal tenderness. which could and diarrhea, which could signify the other causes that I've spoken about already. And this really is an important consideration if those other things aren't present. And in fact, even if they are present, it's worthwhile thinking about urinary tract infection, especially if the patient has a urinary catheter in situ. And the way to diagnose it, because the clinical presentation is so non-specific, is to do a urine culture, a clean urine culture, not taken out of the catheter bag, and looking for the presence of a high colony count of bacteria. In patients in hospital with fever and suspected catheter-associated UTI, we almost always do a blood culture as well. Before I move on to the final two systems, again I forgot to mention the kinds of bacteria that cause infection in the last three systems that I mentioned. So GIT we've spoken about, but intra-abdominal and urinary tract infection is most commonly caused by gram-negative bacilli. So E. coli, Klebsiella pneumonia, and occasionally Pseudomonas aeruginosa in selected populations, but most commonly gram-negative bacilli, and this is what we would target our empiric antibiotic therapy at, also considering the risk of gram-negative resistance. So the last two systems I'm going to go through quite quickly because they are not common, and especially in general medical wards, but there can be CNS infections in hospitalized patients that can cause fever, and of course the most important is post-neurosurgical local CNS complications, either meningitis or brain abscess or shunt infections. And on history, really the things to ask about are recent neurosurgical interventions. If the patient's got has got new neurological symptoms, most commonly confusion, drowsiness, decreased level of consciousness on examination, and potentially neck stiffness. Also examining the local neurosurgical sites. And the critical test to do is CSF examination for cells chemistry and culture. And the final system to consider, although it's again not very common and can be very non-specific in its clinical manifestation, is the vascular system. And infections here leading to fever in patients in hospital are related to endocarditis and perhaps post-operative vascular graft infection. And on history, we would ask about the presence of an intravenous catheter. Remember, Staph aureus bacteremia as a complication of drip site infection can definitely cause endocarditis, and this is an important consideration. And then recent vascular surgery, sometimes at the site of surgery there can be evidence of infection, and that can raise suspicions about graft or endovascular infection. On examination, fever is very prominent, and potentially murmurs can be heard. And importantly, to do imaging and blood cultures, which are frequently positive. So, looking back at this table, you can really see quite a systematic approach to dealing with a patient, to assessing a patient with fever in hospital, going through each organ system or body system and thinking about the causes, and then questions that can be asked on history and key features on examination. And you can see that if you go through this in a systematic way, it's actually not that difficult most of the time to come down on between 1 and 3 differential diagnoses after you've just spoken to the patient and done a very focused examination, and then supported by diagnostic tests. So think about skin and soft tissue infections, most importantly drip site infection, but also surgical site infections and bed sores, hospital-acquired pneumonia, shortness of breath, C. diff diarrhea, patients presenting with diarrhea, intra-abdominal complications from surgery, so abdominal tenderness post-op, urinary tract infections, which can be quite non-specific but have a high index of suspicion in patients with urinary catheters, urethral catheters in situ, and then in specific clinical scenarios, central nervous system and endovascular infections. So I just want to end off by speaking about important ways to prevent hospital-acquired infection, which are probably the most common cause of fever in hospitalized patients. And really the two most important things you can do is think carefully about the management of urinary catheters and peripheral intravenous catheters. So, just to speak about urinary catheters, really the most obvious and important thing to prevent catheter-associated urinary tract infection is to not actually have a catheter in. And there's really only three indications for a urinary catheter. One is patients who are acutely ill, requiring careful monitoring of their urine output, and really only leave it in when you intend to monitor their urine output. The second indication is patients who have urinary retention, either because of anatomical obstruction or because of functional obstruction, so patients with spinal cord injury or other causes of neuropathy, not allowing them to pass urine spontaneously. And then patients with local wounds around the perineum requiring intensive wound care often require urinary catheters just to keep the wound dry. Those are the only three indications. Decreased level of consciousness, incontinence are not indications for a urethral catheter to be in situ and just places patients at risk. Patients like that can be nursed with nappies. When you insert urinary catheters, if the patient does have one of these three indications, it's very important to practice, as always, good hand hygiene. Use a sterile technique, the smallest catheter possible, and secure it properly so that it doesn't cause trauma. In order to prevent catheter-associated UTI in patients with urinary catheters, it's important to collect fresh urine only from the sampling port using a sterile needle and syringe after cleansing the port with disinfectant and not from the catheter bag, because this is important to prevent contamination and potentially over-treatment if you're considering a UTI. Important to empty the collecting bag regularly, and very important to keep the bag below the level of the bladder to ensure good drainage, and also off the floor on a stand. Remember, do not clean in males and also in females the meatal area with antiseptics. It doesn't help. Do not screen patients for asymptomatic bacteriuria. So in patients who are well without fever, do not send the urine for routine culture. It's going to cause over-treatment. Do not treat asymptomatic bacteriuria if it's detected. Don't use, in most cases, systemic antibiotics as prophylaxis. Change the catheter routinely if it's required, and irrigate them routinely if they're required, and every single day assess the indication for the need for urethral catheters. And finally, applying similar considerations to the management of peripheral intravenous lines. So what are the indications for peripheral IV lines? Number one is if the patient requires intravenous antibiotics, and there really are specific infections that always require intravenous antibiotics. So patients with deep-seated infections like meningitis, endocarditis, bloodstream infections, and bone infections, at least initially, almost always require intravenous antibiotics, and that is an indication. The second indication is that patients require IV fluids or nutrition because oral administration is not effective or possible. So patients might be too ill to swallow and can't have a nasogastric tube. If patients have poor absorption, either because of severe vomiting or ileus, and in patients with oral tracheal intubation, but often we can use NG tubes and crush medication and give water and nutrition via this route instead of using intravenous administration. Patients with hemodynamic instability clearly need an IV line for resuscitation. Often we use intravenous antibiotics as initial therapy for severe infections, like a severe pneumonia, for example, but very early we switch to oral antibiotics when the patient is able to swallow, even while their infection is persisting, especially oral antibiotics with good oral bioavailability, which most of the beta-lactams have. And then the final indication is if there's no appropriate oral antibiotic or oral medication available. So, for example, if a patient requires vancomycin, that's only available in the intravenous form and can only be given via that route. If a patient requires blood, they can obviously only get it intravenously. Very important, if a patient requires intravenous catheter, then it must be inserted correctly with strict compliance to hand hygiene, using a sterile technique in all circumstances, every time. The skin must be cleaned with chlorhexidine, sterile gloves must be used, a sterile pack, the smallest needle possible, and important to secure properly. Every single day, patients should be examined for signs of inflammation around the drip site. Remove the IV line if there is any sign of drip site inflammation. It's not really recommended to routinely change the IV catheter, only if there's signs of inflammation. But every single day, it's important to reevaluate the indication for IV lines and try get it out as soon as possible, because that will obviously prevent drip site infection, which is potentially life-threatening. So to summarize, fever is a common and important problem in hospitalized patients. Fever is defined as a temperature greater than or equal to 38 degrees Celsius. Although there are many causes, taking a systematic approach on history and examination is a very helpful way of trying to sort through these, making a diagnosis quickly and focused investigation. Hospital-acquired infections, which are the most common cause of fever in hospitalized patients, are preventable with good hand hygiene and following correct indications and management for intravenous lines and catheters. I hope you found this useful. Take care and stay safe.